So what we're going to talk about this evening is foot and ankle fractures. Or I'm going to focus on going through some basic anatomy to start with, looking at the foot particularly, and then spending the majority of the next 40 minutes speaking about the ankle and fractures associated with that. And then at the end we can go through questions that haven't been answered already. I'm sure we've already gone through all this stuff, but I've just followed the YouTube channel. You should follow the YouTube channel and the Instagram channel, and you'll make Andre and Emma very happy. Okay, so just a brief overview again. So we're looking at the things that are most common. When you look at any sort of orthopaedic training website, ankle fractures are very common, and they're very good to understand because you get a basic physiology as well as the different management options that exist. Like I said, we'll go through how to assess as well, and then what the management options, and finish with some of the complications that might be applicable to the patient group. So I thought first we'd start with the bones of the the foot bones, and in particular to focus on the calcaneum and the tarsal bones. That is because they have, whilst a lot lower fracture level, they do occur. And the calcaneum fractures account for about 2% of all fractures. So if you just follow my mouse here, we're looking at the talus here. And as you can see, it's quite a nice sort of shaped rhomboid. And then over here, we have the calcaneum on the lateral view. Okay, so these are normal X-rays, and there's going to be lots of images up through this talk, and I will point out as we go along, particularly anything that's abnormal or things to look out with. Okay, fine. So calcaneal fractures, you can see when you get the AP and lateral X-rays, which is your standard imaging. Taking the history from this patient, they are often either sort of a few different patient groups. So primarily, they can be patients of multi-trauma. So they will often come in having a history of falling from a height, anything that will count for two fractures bilaterally with pain and discomfort, and as well as soft tissue swelling. If a patient does have bilateral calcaneal fractures, it's very important to look for other injuries, particularly going more proximal, thinking about pelvic, acetabular, and lumbar vertebral. The high force that is put onto the calcaneum can. Tarsals will often present with pain over the sort of the front of the foot, and sorry, my internet's unstable. Am I coming across clearly? Okay.
Now it's a bit better. It had a bit of hiccups in between, like for the past 5 seconds, but I think it's fine now.
All I was mentioning was the pain and discomfort that can be experienced over the dorsum of the foot. It's beyond the scope of this talk to talk about particularly the in-depth management of these patients, but the important thing is to, and I will reiterate it on again and again, is to get a good history and examination, and looking for soft tissue injuries over any particular fractures. Okay. Again, I want to briefly mention the metatarsals. So it actually comes up particularly when we're thinking about ankle fractures, but it's worth just identifying them by themselves as well. So here we have 1 to 5 of the metatarsals on this our right foot. And a bit over here, we just have a pictorial representation. It's slightly cut off here, but what I'm trying to show is the 5th metatarsal, which is of particular significance. So again, this happens in patients that can be quite fit, so like calcaneal fractures, where there's a stress element to it. So thinking about athletes, military personnel, that kind of thing. People in their 30s that present with jobs that involve a lot of time on the ground. These patients will present with lateral foot pain and an inability to weight bear in most cases, but with a lot of pain. What you can see here just on this X-ray, so it's an oblique view here, and I've not included the rest of the X-rays because I think this is the most important one, is you can see the break in the cortex just here, okay? There are several types of 5th metatarsal fracture, but the important thing to note is that it is common with an avulsion of where the peroneus brevis inserts into the 5th metatarsal, and how you manage it is to put them in a walker boot. So this will allow full weight bearing. These patients need to be in this boot for probably 6 weeks, with serial examinations along the way, and will actually have quite a lot of discomfort, pain, aches, very sort of generalized discomfort to that area for 3 to 6 months after the initial injury. Why this is also an important fracture to be aware of is that it comes associated with ankle fractures, which I will come on to talk about shortly. But when you are getting a patient with a history of what sounds like an ankle fracture, it's really important to include imaging and examination of the foot to rule out an inclusion of a metatarsal fracture as well. Lovely. Okay, so I want to just focus for the next few minutes on the anatomy of the foot itself, of the ankle itself. And what this X-ray is really good for is it gives you a really nice clear picture of the distal tibia here coming along and forming the medial malleolus, of the fibula coming down laterally and forming the lateral malleolus, the talus that we've already talked about, which sits very nicely below it on this hinge joint, and then the foot bones that you can't really clearly make out from this image. This X-ray is a mortise view, and I'll go on to talk about that in a few minutes. But what I also want to talk about is the importance of ligaments as to the stability of the ankle. The ankle is very crucial. Not to paint too much of a picture on it, but the force that comes through the ankle is 5 times the weight of the individual. And so having it in a particular position and having the stability of the ankle is paramount to how a person can move. And actually trying to achieve a good position post-operatively or post-reduction is paramount to someone being able to have independence again. Okay, so we've talked a little bit about the bones. Let's move on to the ligaments. So there are 2 main areas to talk about, the medial and lateral ligaments. And I've got another slide, the next slide, which can show you a bit more about the breakdown. But the important thing is to talk about the deltoid being part of the medial ligament, and that being a notable ligament. And then the collection of lateral ligaments that insert into different points of the midfoot as well as the distal fibula. Syndesmosis is a term that is a little bit perhaps confusing, but what it involves, why it's important is because it gives a congruency to the fibula and tibia. It brings them together and gives stability. Now, all of these factors are important for allowing a correct positioning of the tibia, fibula, and talus. Highlighted this space here, which is called, which is important because it's to look for the mortise being in position. So we want everything to be related properly. If it is not, then you are at risk of instability, you are at risk of pain. And therefore, that is why we go on to talk about, if I just slow it down 2 slides. Where's it gone? I'll come back to it. While we look at the stability of the ankle joint itself. Fine. So this goes into a little bit more detail. As I mentioned, on the medial view here where my mouse is on the right side, we've got the deltoid ligament and its insertion from the distal end of the tibia onto the calcaneum talus and onto the navicular. And then on this side here on the lateral view, you can see both. Why I really pull this up is because it shows you that the different directions that the different ligaments go in and their inclusion posteriorly as well. Because what we can't see from this mortise view X-ray is we can't see the posterior malleolus, so the 3rd malleolus. And why that, and the ligament that is indicated here provides the stability and allows for good movement and flexion of the ankle joint. So, ankle fractures. I'm going to go now into the history and examination, and as well I will talk you through some of the common image findings that you will get to see. Okie dokie. Fine. So very obvious, and I'm sure it's taught every joint you will see. Look, feel, move, and special tests. This is a very grainy shot of Tiger Woods, who very nearly broke his ankle with having an accident 2 years ago. Gone for fractures. With the ankle, it's no different to any joint, and we start very basically looking at the individual end of the bedigram very clearly. So, how does this patient look? What is their support? Have they got mobility aids? Are they using a crutch to mobilize pre-injury? When I'm looking at them now, can I see that they've got footwear with them, and how does the footwear look? It's very important to actually pick the footwear up and look to see if there's asymmetry. So, are they wearing down the shoes in a different way pre-injury? Can I see any changes to the skin? So things including your differential of someone coming in with foot pain and ankle pain. So is there a swollen joint? Is it red? Or is there erythema around the joint space? Is there a wasting of muscles that I can see? Is there asymmetry from the left to the right foot? Can I see any valgus or varus deformity? And as much as possible, you want patients to be either standing or sitting. But I realise in some patients with ankle fractures, that's not possible. But for a good ankle exam and foot exam, you want to be able to look both anterior and posteriorly, especially to look at the arches and, like I said, the valgus and varus deformities. Things also to look out for. Are there any skin changes, sort of chronic? So things like lichenification or psoriasis, which might be inducive of diabetes or any other type of arthropathies that can cause joint discomfort. Don't forget to look at the sole of the foot, and especially in diabetics, that's very important. And part of an examination of any of a diabetic person would be to look for neurovascular. So we'll come on to that. Now, gait. Obviously, in a patient you're suspecting an ankle fracture with, you will not get them to walk per se, but in any sort of exam that you can, you would assess the patient for a high stepping gait, their fluidity of movement. So is there clean strike off the ground and put back down? The image here on the right is helpful because I think it shows quite clearly what can happen within the sort of 24 hours post-injury. This is a fracture blister. So you can see it's nice and tense, it's clear serous fluid in there, and it's extending around the ankle joint itself. What you can also see more generally is that the skin is quite tight and quite shiny, and that just really indicates the amount of edema patients can accumulate very quickly after an ankle fracture. I'll go on to reiterate it again, but the ankle fracture or any sort of dislocation injury, the bone is deep to the soft tissue, and the soft tissue, you can fix the bone, but it does not make a difference if you have no skin to work with. And therefore, seeing this is quite common, but it's also an indication of how severe the injury was and how high an energy transfer has occurred. So feel. So like I said, any changes in the temperature with the erythema, any warmth, any delayed capillary refill time, any changes in terms of the texture of the skin itself, so more thinking about chronic changes. When you feel the foot and ankle, you want to feel every joint in itself. So much like the hands, you will squeeze, sorry, I can't bring my feet up, but you will squeeze your MTPs. You will also squeeze each toe individually and feel for pain and discomfort in the joint. You'll assess for the neurovascular status by looking for the dorsalis pedis, as well as the posterior tibial. And you can do the dorsalis pedis by getting the patient to flex their big toe, their great toe, back up towards their nose. And if you feel just laterally to that, that's the best way to identify the dorsalis. With diabetics, as I mentioned, it's very important to make sure that there's good sensation bilaterally on both feet, and to do anchiobrachial pressure index if you're concerned in vascular patients as well. What I've also shown here on the picture is some redness and erythema around the dorsum of the foot, which actually indicates a patient with gout. When you're actually moving the ankle, you are obviously restricted by what the patient is able to do at comfort levels. But you are aiming to do a few different movements. Now, there aren't pictures that do a great job of it, and I'm afraid I don't have a video, but I will talk you through exactly what we need, what you are looking to do in a best case scenario where your patient is able to comply with the examination. What you will ask is, you will ask them to dorsiflex their foot. So dorsiflex the ankle, which is to bring it towards their face. And you're looking to get between a 20 to 40 degree movement, which is normal. And you will also ask them to plantarflex, which is essentially pointing their toes like a ballerina. And if you get about 30 degrees on that, that's good as well. You will also assess them for inversion and eversion, as this is important to what the history of the injury might have been. And you aim to get 20 to 30 degrees on both movements there. You can also assess the foot, the great toe itself, and ask the patient to do dorsiflexion and plantarflexion as well. To complete any examination, you will of course do the special tests that might be associated with that joint. And in this case, it would be to do Simmons tests to look for the Achilles heel and to make sure that it has not ruptured. But I know that there's going to be soft tissue talks, or has been already, so I won't go into that anymore. Finally, what is really important to say is, particularly with the ankle, is you can do this examination as part of your initial history and exam, and view the x-rays, get the rest of the history, see the bloods, and that's all part of your giving your differential. But as soon as you make any intervention to that joint, so whether it's dislocated, whether you put it in plaster of Paris, whether you manipulate it in any way, you need to repeat your examination. In particular, you need to assess the neurovascular status of this joint. And that particularly involves assessing the dorsalis pedis, assessing the sensation to the area. Is it the same as it was previously? Is it the same to the other limb? And making sure that there's no changes to capillary refill as well. Okie dokie. Now, Ottawa ankle rules are something you'll hear about through A&E, and it's used here a lot in Britain to help A&E clinicians or primary care clinicians decide whether they want to image a patient's ankle. It's for people that come in with foot and ankle pain that are able to give a history. So it is not particularly useful for patients with low GCS or those that are not able to give a history at all. And how it works is you ask a patient, have they weight beared since the injury? So have they been able to stand, walk around at all? Or are they able to walk 4 steps within the department? If there are if there is pain to these areas here, so you've got the 6 centimeters of the distal fibula and the same on the medial aspect on the distal tibia. If there is pain on the midfoot zone here, so just as the ankle, just as you come onto the foot on the dorsal aspect, and is there pain on the 5th metatarsal? For any of these to be positive, so if there's pain, or if they're not able to weight bear or have not weight bared since the injury, then that is an indication to image the foot and ankle. At this stage, you would be asking for plain x-rays, and they would be an AP, lateral, mortis, and depending on the history and exam, and if you've got 5th metatarsal pain, you would also be asking for a foot imaging, which is an AP unoblique. This is what I was talking about earlier when we were looking at the basic anatomy of the ankle, and I thought we could have a quick look at some of so patients with normal anatomy and looking at the x-rays themselves. So very clearly we've got the difference between AP and mortis, and the important thing about mortis here is you can see clearly that the distance, when I put my mouse here, that the distance is the same here as it is here as it is here. Now that's very helpful actually for a rough guide when you're looking at the images, because it sort of indicates that there's about the 4 millimeter gap between the talus and the tibia or fibula, and that indicates congruity in the joint space. On this side, you cannot assess that clearly, and that's why it's really important to make sure you get the mortis view when you're doing your primary imaging. If we come on to the lateral aspect, and here I wanted to show you the posterior of the tibia and fibula. Then we've got the talus here and the calcaneum here. Now this is a normal X-ray, and what you can see is this nice dome of the talus there is no break in the articular surface, and there's a nice congruity which will allow for the plantar dorsiflexion. You can also see that there's no changes to the soft tissue here, so you wouldn't be concerned at all. You can see that there is clear continuation of the calcaneum and that there's no disruption. This image here on the right I have brought up because I want to tell you a little bit about posterior malleolar fractures. So we've moved on from imaging and anatomy, and we'll come on to the actual fracture patterns to look out for. Posterior malleolar fractures are not by any stretch the easiest ones to look at, but it's important to be aware of them and to be mindful to look for them. And they are part of your standard imaging. In this X-ray here, we can see, if I just show you with my mouse, a disruption in the cortex, just here. And what you can see is that there is, if you believe me, a tracing line down here, down the posterior malleolus. Now, I don't want to show you the AP and mortis views at the moment, and I just want to focus on the posterior malleolus. So what we have is a fracture there. Now, it is not translated particularly. There's no movement of the fracture itself, but it is present. Posterior malleolar fractures are something that requires often further imaging, including CT, and also to obtain the stability of that joint going forward will likely require manipulation of the other two malleoli to obtain congruity of the talar joint again. Lovely. Let me just move on. So this is the big one. These are the Weber classifications, A, B, and C. I'm going to spend the next few minutes going through each of the fracture patterns, as well as talking you through some of the management options that we have for them. So again, these X-rays are mortis views, AP, of mortis views of the left distal tibia and fibula left ankle joint. The Weber classification is one of the classifications used in orthopaedics to help direct management. There are others that I can mention the names of at the end, but they're not important at the moment. What the Weber classification is to give you a guide on the joint. So there are fractures that we are happy to accept with non-operative management, but it's mostly based on the location of the fracture in relation to the fibula and the mortis. So if we talk about Weber A here for a minute, what you can see is there's a fracture in the distal aspect of the fibula. The fracture itself is inferior to the mortis line, so along here, it's inferior. And after having done a history and examination, so you've assessed the neurovascular status and you've assessed the patient's history with no other injuries and you've done ATLS as appropriate, you can look at this fracture in isolation. And when thinking about how you manage this fracture, we are able to say that there is stability. And by that I mean we have a fracture that needs to heal, but we do not have a disruption to the ligaments, particularly of the syndesmosis, which means that we can manage this fracture conservatively. And the conservative management option we will use is a walker boot. So this patient will be put into a walker boot for about 4 weeks. They will have a review within fracture clinic within 7 days, and they're able to fully weight bear. Now, again, it takes a few months for the fracture to fully heal, but there is no restrictions to their movement with the boot on. Weber B is the next one along. And now this is the sort of grey area of the classifications. And so we do a lot of safety netting with this patient group. What you can see here is that we have an intact tibia, but we have an oblique fracture of the distal fibula that lies at the level of the mortis and continues slightly more proximally. With this patient group, there are a few things to be mindful of. The two management options we have available are conservative or open reduction internal fixation, where we can plate this patient to stabilize this fracture. In the A&E department, what you will do is you will attempt to reduce this fracture and obtain good opposition in a plaster of Paris back slab. You will re-image after assessing the neurovascular status and look to see if you are happy with your reduction. In those patients that you have achieved good reduction with a back slab and that are comfortable, they've settled down after manipulation, then it is possible to send them home with a back slab to be seen again in fracture clinic in 7 days' time. The reason we bring them back to fracture clinic and re-image them there is because we want to assess the stability. We want to assess, has the syndesmosis held and is therefore a stable fracture, or has in fact there been a disruption to the syndesmosis, which by its nature means that this fracture is no longer stable and requires operative intervention. This image here shows a post-operative film of a patient with a Weber B fracture. And what you can see is there's a plate going down the lateral aspect of the fibula, and the screws are coming across above and below the fracture site, which will be in here. And this large screw going across most of the way across the tibia is a syndesmosis screw. So this screw acts to replace the ligaments that are damaged within the space between the tibia and fibula and provide stability to the joint. Okay, so Weber C. So this fracture pattern, you can see significant disruption to the mortise, and you can also see this distal fibular fracture that is well above the mortise joint itself, well above the line of the mortise joint. And from this, we can assume instability. This patient is not suitable for conservative management and does require operations. And I say operations because the injury that comes associated with this, like if I go back to what I was saying about soft tissue, is there will be a significant amount of soft tissue damage. And therefore, we are unlikely to be able to put initial plate and screws in, as the soft tissue swelling will accumulate significantly, that there would be poor healing. So in the first instance, we may well have to use external fixation. And so what this image here on the top right shows you is the insertion of pins into the proximal tibia and fibula, as well as into the calcaneum, completely bypassing the fracture itself. And using this frame, so ring frame, we can achieve stability whilst allowing the soft tissues time to normalize, so the tension to leave, the swelling, the edema and swelling to dissipate before we do an open reduction in front of internal fixation, where we will have to stabilize the fibula as well as whatever else is required to achieve mortise. What I've shown here in this bottom image is 2 screws that are actually gone into the medial malleolus. And again, I'm going to go on and show you some more images of bimalleolar and trimalleolar fractures. But this again it's just nice to show you in isolation the 2 screws that we can use. So medial incision here, where we use it to stabilize and realign the fracture. Okay, so this is a bimalleolar fracture. I've given the name away already by the title, but I think it's really important to just use the images and one word to really hammer it home. These are 2 x-rays of a right foot. And if I start with the AP, we can see a disruption to both the distal tibia as well as the distal fibula. And this causes a translocation of the and causes talar shift. What you can see here is is just the end of the malleolus is separated here. So you can see this break in the cortex, and you can see this slight translocation of the distal fibula. This foot is at an unusual position, and that is possibly due to pain or the radiographer trying to achieve satisfactory image quality. On this lateral X-ray, what I'm looking for is not just the fact that there is some soft tissue injury, but I'm also looking down this posterior aspect of the tibia to see if I can see any break in the cortex at all. And there's not in this case. Also, as good practice, you want to be looking to make sure there's no changes to the calcaneum cortex or to the talar dome. And we can't see anything there. So, a bimalleolar fracture. How we have to act on this is we bring them to theatre for open reduction for sternal fixation, where we have to put a plate into the distal fibula and some screws, like I showed you before, into the end of the malleolus. End of the distal end of the tibia into the medial malleolus. And what we're aiming to do here is to achieve an adequate talus and the mortise to be in the right position. And we've used this extra screw here to provide stability across the fracture line. So while these are different patients, the screw here is being used to stabilize this fracture, as well as the plates. Now, what you will also see is this patient is in cast. And that is because despite these plates, they are not replicating the strength of the native angle. So they don't have the strength just yet to fully weight bear. This patient will be in a cast and will be seen again in a few weeks upon discharge to toe touch and then fully weight bear. There will be scars bilaterally, so the medial and lateral aspects of the malleolus, but they should be less than 10 centimeters in length. If we move on to trimalleolar, the trimalleolar is the medial, lateral, and posterior malleolus all showing disruption. These are often obviously a lot more complicated in imaging, and actually it could be appropriate to have further imaging other than plain radiographs. What you can see here is the distal, the medial malleolus is disrupted. The distal fibula lateral malleolus is disrupted on the AP. And then on the lateral, you can see, and on the lateral, you can see a disruption to the cortex of the posterior malleolus. We've lost the mortise, and so this joint is unstable and requires fixation. Again, the same principles apply as a Weber C, of which it is that the soft tissues are going to be very angry, and you need to give them time for the edema, the fracture blisters, to reduce in size before taking this patient to theatre. That can often be 7 to 10 days. And so in the meantime, you can either manage them in a back slab, so not complete circular slabs, and allow the swelling to dissipate, or external fixation as appropriate. Now, I wanted to show this X-ray because it really caught my eye, and I think it really hammers home the importance of assessing a patient's neurovascular status. What you can see in this AP image, X-ray, is a fracture dislocation of the ankle joint. You can see that both the distal tibia and fibula are dislocated from the talus, and that there's significant tenting of the tissue. So this is just what's separating this bone from becoming an open fracture. This is an emergency. Alongside these fractures and dislocations, there is significant stretching to the vasculature, as well as the nervous supply to these bones and soft tissues. And therefore, it's an emergency to reduce this fracture in the A&E department. This should be, if you've got 10 jobs to do, this should be one at the top of your list, unless there's nothing else really. This requires an immediate reduction in resus in your A&E department with imaging to assess if you've achieved a good reduction. This patient should be monitored closely because you're at risk of developing compartment syndrome, and you need to check pain pressures. You need to check the patient for pain disproportionate to what you would expect serially over the next few hours. In particular, you need to be thinking about the compartments of the lower limb, so the anterior, posterior, and lateral of the lower limb. This image shows the post-operative imaging of a trimalleolar fracture. So we've got the mortise, the lateral, and the AP view. What you can see here is there is a plate down the fibula stabilizing the lateral malleolus. There are two screws going into the medial malleolus to stabilize there. And posteriorly, there's a posterolateral plate that is stabilizing the lateral malleolus. It's a lot of metal work, but if you don't do this, you're going to continue to have an unstable ankle and a patient that just can't weight bear and mobilize independently. I just want to mention as well a few add-ons to the typical ankle fracture. And a meson nerve is an eponymous title for a French surgeon from the 1800s. And what it describes is a patient who has a severe translocation of their talus with syndesmotic disruption and a proximal fibular fracture. So the mechanism or the biomechanics of it is the pressure comes through the syndesmosis, the energy transfer comes through the syndesmosis, ruptures the syndesmosis, and because this is a polament shaped joint, much like the radius and ulna, you have to have an equal and matching force, which will be a proximal fibular fracture. And it's important to look out for these, as you need to make sure that you obtain realignment as well as image the whole length of the bone. Fine. This is a post-operative imaging of management of a meson nerve where you have used the syndesmotic skew to reenact the emotion of the syndesmosis because it is no longer functioning, and you have stabilized the distal fibula. A tibial plafond fracture is also known as a Pilon fracture. And much like a calcaneum fracture, this is a fracture that you need to think about in ATLS, because what it indicates is a patient who's had a high energy injury. And so after going through your ATLS principles, which I know Rory did a few weeks ago, we can then look at this imaging. This patient will not be able to probably, with associated injuries, not be able to perform much of an examination and will be a very poor history taker. But what you can do is you can look, you can see any disruption to the normal length of the limb compared to the contralateral limb. You can look for any changes to the skin. So vasculature, is there tenting? Is there any open? Is there any breaks in the skin which would indicate an open fracture? You need to make sure you assess the neurovascular status, so capillary refill, dorsalis pedis, and a checking for sensation, comparing both limbs. And then you need to get some imaging. So if we look at these x-rays now, what we've got here is a mortise, a lateral, and an AP. What you can see is there is multiple bony fragments. There is impaction probably as well, and a significant degree of comminution. This is a very unstable fracture, and actually is a hard one to manage, in the sense that post-operatively, this patient is likely to suffer from arthritis within the next 5 to 10 years. So we've got initial imaging, but most likely this is not satisfactory. What you can see here is there's a significant disruption to the articular surface. So we can see that there's a fracture here, as well as fractures here, which is separated the fibula from the talus appropriately. We can see that the disruption is significant enough that we have to do some operative planning. It's important to get a CT. So this is a different patient, but what we've initially got is their initial X-ray. We've then got the CT of where you can see the fractures here in the fibula, as well as here in the tibia with the rotational aspect. And then we've got a 3D reconstruction, which just shows you how impacted the fracture is on, excuse me, the fracture is onto the distal tibia and fibula. This patient needs a significant degree of management. They're going to be inpatient for probably quite a while, whilst we initially manage them with external fixation to stabilize the fracture, obtain neurovascular compatibility and allow the soft tissues to heal, as well as allowing for a decent amount of preoperative planning. What you can see here is an extensive reconstruction with a long plate along the medial aspect here along the tibia, and a further plate here stabilizing the fracture in the fibula. They've had multiple screws to bring back the comminuted and all the different fragments in the aim that we obtain this ankle joint that we're so keen on, with the 4 millimeters around each aspect of the talus. In a patient like this, there's things to be thinking about out with just the initial fracture. So I've already mentioned ATLS and any other associated injuries they might have. But you've also got to think about, well, what has predisposed them to this fracture? And what you will also do, not necessarily in the immediate, but you will also need to investigate for things that might cause weakness in the bone itself. So assessing a bone profile and looking for things like a myeloma screen. If I can just talk to you a little bit about XFIX as well, and I think it's been mentioned before, but in a patient with this high velocity injury, like I said, there are likely to come along with other injuries, and an XFIX is very useful for doing quick operative stabilization of a joint in a patient that is physiologically unstable. So when we only have in theatre a short period of time to have them on the anaesthetic table, to give them a second insult of an operation, then an XFIX is actually fantastic because there's a lot less trauma to the patient than having to go through an open reduction, which will happen when they have been stabilized. Just of note here, you can just starting to see the callus formation forming underneath these plates. So if we move on to complications, and if we break them into 3 areas, so intraoperatively, early, and late. And these are the sort of things that I think are particularly important to the surgeon at the time. So are you managing to obtain a good reduction? When you're using your imaging intraoperatively, are you happy that you have obtained a good positioning and good relation of the talus to the tibia and the fibula? And are you able to say that this is a stable joint with the reduction you've done? Now, that also occurs in the A&E department when you are casting a patient. Other things to look out for in the immediate post-operative period is wound breakdown. So I've talked multiple times, I know it's harking on, but about the integrity of the skin being paramount to healing. And there are lots of horrible images that you can see of exposed metalwork, because the soft tissue around the ankle is not great. There is not a huge amount of subcutaneous tissue, and requiring it to heal, so the skin to heal without opposition and not under tension, requires the edema, swelling, and the blisters to have resolved or to have significantly improved. Infection, by that I mean both superficial and deep. And you've got to think again about osteomyelitis, all that kind of thing. And late, I mentioned about postoperative arthritis being more prevalent again, in the more severe the fractures, so Weber C, the Pilon fractures, those sorts of things patients are particularly vulnerable to developing arthritis. As you are having to, particularly in this, you are having to expose a large amount of the periosteum, you are putting at risk your lymphatic drainage, and patients can experience a significant amount of lower limb edema postoperatively. Now, it's pretty standard for everyone to have edema postoperatively, but it should resolve. But for some patients with more severe fractures, the integrity of the lymphatics has gone and will not be retained. And of course, malunion and non-union. There's one more I haven't included in here, and I suppose it's more just for patient comfort. So if I go back here, this is lovely. There is good gap between the soft tissue, the skin, and the bone itself. But over time, once the fracture is healed, patients may present to you with discomfort, they're able to feel the tops of the screws, they're able to feel the plate. And that might also be a complication that can be remedied by removal of hardware. Well, thank you very much for listening to me. I hope that was okay.